I'll turn to Brad. Brad, what are some of the patient factors when you consider in deciding how to start it, how do you monitor it, and again, the expectations you give to people about the medicines?
Sure. Well, I think for the cholinesterase inhibitors, they're efficacious they've been demonstrated to be efficacious, as Mark said, in patients with mild dementia due to Alzheimer's disease. There's also efficacy data in patients with Lewy body dementia. I think some of the best responders to these medications are often people with Lewy body dementia. There have been other smaller studies that suggest that they might be helpful with vascular dementia or with other pathologies that lead to memory impairment, including multiple sclerosis and traumatic brain injury. So there are a variety of potential patient populations that could benefit. I think in general, there hasn't been data to show that they've been effective in patients with mild cognitive impairment, even if it's thought to be due to Alzheimer's, but those studies have not really been conducted in a focused modern way. So I think we often see off-label use of these medications in patients with amnesic mild cognitive impairment in particular. And I think there's anecdotal evidence that they benefit those patients. So I think it's always important to continue along the discussion of diagnostic disclosure that Mary mentioned by trying to understand what the patients' and families' interests in medications are, what their experience with medications is. And I think it's often the case that when we explain that these medications do have side effects like any medications, but that for the most part they're quite manageable, that a trial of a cholinesterase inhibitor in a patient with mild Alzheimer's dementia is met well from the perspective of the patient and family member. There's often the hope that they can do things beyond what we believe they're going to be able to do. So I think it's always important to set the expectation that not everybody even has a noticeable response in their daily lives to these medications. And even if they do, they don't, as Mark said, affect disease progression in a way that would suggest slowing of the disease process. So I often draw a curve that shows progression if you don't treat it, a parallel curve that is up a little bit to show that you might get a little bit of a boost in your memory or other cognitive abilities, but that the rate of progression is going to likely remain largely the same. And then later on, if you add memantine, you might get a similar boost, but again, the rate of progression overall will be the same, but maybe you would maintain function above where you would have been if you weren't taking this combination therapy, as you've shown with some of your own data. So I think that setting those expectations, and often with a graphical support to really drive that fact home that the progression is going to still happen, and that we may see some benefit, but even if we don't, just because the patient is declining doesn't mean that the medicine's not working. And I think that can be a hard thing to judge. Sometimes what we see is that if people, the clinician and the patient and care partner, have been on donepezil or another cholinesterase inhibitor for a year and they're worse off, everybody kind of feels like, is this thing really even doing anything? You might do a trial off of it and the patient is clearly worse than they were when they were on it. So that can be one way to make a judgment. I think a lot of times if the patient's tolerating the medication well, we just hope that it's working and continue it. And so, I think some patients don't tolerate these medications well. They have substantial GI side effects that are persistent, and that can be challenging. Often trying one of the other cholinesterase inhibitor oral medications is the easiest way to go in seeing if they might be able to tolerate one of the other medications in the same class. There are also transdermal formulations that can be tried as well if the person is particularly sensitive to GI side effects. So I think those are some of the things that I use in my consideration. When a patient clearly has a non-Alzheimer form of dementia, such as frontotemporal degeneration, these medications don't help in terms of the AD medications. They sometimes can even sort of activate patients in ways that lead to more disruptive behavioral symptoms. So I think it's important to talk about the standard approved medications. It's also important to talk about the symptoms that we can treat with other kinds of medications that are often very helpful in dealing with some of the symptoms that Mark has been talking about, in relation to mood-related symptoms, potentially psychosis, which can be so devastating for families to deal with. So I think considering those medications, including ones with efficacy data or sometimes just off-label use, is important to discuss with patients and families.